So our next topic is going to be on mental health. And I don't know where it went. Let me stop recording. Okay, now I lost y'all. Sorry guys, I'm switching windows real quick. Okay. So I know y'all have had a long day, but this is something that we haven't ever talked about mental health in this curriculum. So maybe this is a little something new you'll find fascinating today. I actually think the world of psychology and mental health is so cool. I love even the weirder, the better. I love it. So I don't know why I like that. And maybe that's why I like traumatic brain injury so much, because they have all the behavioral problems, and that's just so interesting to me to deal with. So, okay, so I switched over to this. So you should see the PowerPoint that says Introduction to Mental Health for PTS. Okay, so let's just give a little bit of some stats. The field of psychiatry and the world of psychology is not a new field, but it hasn't really been very widespread and hasn't really been accepted in the modern medical community for that long. Really around the days of around the turn of from the 18 to the 1900s, that's kind of when psychiatry and psychology were really starting to become more prominent and more accepted in science, and people were taking them seriously. But in the early days of medicine, people thought that doctors thought that basically mental illness was widespread, super common all through the world, that people all the time had mental illnesses that came and went, and that people could get mental illnesses and go crazy at any time. That was their widespread belief. Even as late as 1950, believe it or not, some psychiatrists did a study and found that just the population of Manhattan Island in New York, just Manhattan, that 82% of the population had signs of mental illness. Now, we know that sounds completely insane. There's no way that 82% of the population of anywhere is going to all have mental illnesses, even if they're all different. However, that's obviously a flawed study, biased study, and obviously they were counting things as mental illnesses that obviously are not mental illnesses. So by the late 1970s, psychiatry had finally come into its niche in the world, and was a prominent medical field. So with psychology, as far as being able to study the mind and work with psychiatrists and provide counseling, social workers were starting to come into play, and counselors were starting to become more common jobs out there for people. But still, there was a big stigma against mental health, so people weren't seeking those services. But a study in 1978 found that they did kind of the same study that the 1950 study did, but they found that about 15% of Americans had signs of different mental illnesses in one given year. So what that means is that in 1 year, about 15% of Americans had one or more signs of a mental illness. It doesn't mean it was a permanent mental illness, because what you'll find in a minute, not all mental illnesses are permanent. Some of them are temporary. And some of them are very, very normal to go through at different times of our life. But the current figures of about 15 to 20% of people having mental illnesses is still the figure that is currently held today. So currently, they say in of about adults in the US. And these are true for, these stats are really about true for other illnesses as well. I mean, I'm not illnesses, other countries as well. These are about the same globally. About 20% of adults experience some form of a mental illness every year. It's not as well documented as children, but they still think that about 20% of children have signs of a mental disorder with some kind of functional impairment. They think that they can grow out of that and really early on with the right type of counseling, and but that only 5 to 9% of those kids will grow up to become mentally ill adults. Older adults or older or geriatric age people, 55 and older, still about 20%. Dementia and Alzheimer's are not included in those figures. Dementia and Alzheimer's are not considered a mental illness. Those are considered organic illnesses, meaning that they affect basically the organic structure of the brain. That is not what's going on in a mental illness. This is more of a chemical thing of the brain. Like I said a minute ago, don't think that this doesn't mean that 20% of the population has a permanent mental illness, because things like depression can be a mental illness, depending on the cause. But just because a person is depressed at one time of their life and has to take medication for it, doesn't mean that they're going to be permanently depressed and on meds for the rest of their life. They can learn to deal with it, come out of depression, and then live a normal life. Sometimes it relapses, sometimes it doesn't. Sometimes anxiety disorders are like that, sometimes they're not. But as you'll see, different things or different types of mental disorders act very different ways. So the rest of this, well, let's keep going. It's don't worry about these costs. I just want you to know it takes we spend a lot of money this is over 99 billion annually. It's well over $1 trillion a year just in the US treating mental disorders, substance abuse, and dementias. And I don't know why I could only find, 69 billion is for mental health services alone. The rest of it is for substance abuse and dementias and stuff like that. But about 69 billion, and it's probably this slide, I made this PowerPoint about 2 years ago. So those figures are probably much higher by now. Most all of it is paid for by private insurance and out of pocket. Even if you have good insurance plans, private insurance, for some reason, and this has been the case for a long time, but the good news is it's changed a lot, it's changing rapidly, especially in the last 5 years. Even really good private insurance used to have really sucky mental health care. Like you could have the best coverage for everything, but to go to a psychiatrist or to go to see counseling, even to just a master's level counselor, they would not cover it. You would have to pay for it all out of pocket, or they would cover it out of network. So they would cover pennies and you would have to pay for almost all of it yourself. Now that's almost that's almost completely reversed now. Now mental health care is seen as so much more important in the medical field now, that insurances have really come a long way, especially those that follow Medicare guidelines. Unfortunately, though, those that do have mental health issues, those especially with severe mental health issues, are not able to afford private health care. So they are not able to afford going to the doctor, or they can't afford to get the right kind of care they need. So their care goes untreated, or their disorder gets worse, or they just live a life untreated and they don't live to their full potential, which is very sad. And that happens in the richest nation in the world. Go America. How is a person with a mental illness diagnosed? There is not one test, blood test, not one lab test, not one scan or tissue sample of any type that will indicate that you will have a mental illness of any type. There's not any kind of test that they can do. Every other medical field out there, they give you a test. They have to give you an objective test to give you an objective diagnosis, except in the mental health care field. It's all out in the open there. It's all a ball game of trial and error. So, what they usually do, the diagnosis comes from lots of what they do. The psychiatrist will often see you for 2 to 3 initial observation periods where they do interviews, and then they're going to ask tons of questions, and then they're going to basically put together what they think is what they think was the most common denominator of all your interviews, and they're going to give you a diagnosis. Okay, there is a gold standard, kind of the psychiatrist's bible, if you will, for diagnosing mental illnesses, and it's called the DSM-5. It stands for the Diagnostic and Statistical Manual of Mental Disorders. It's updated every few years, and it's currently in its 5th edition. The 6th one should be coming out soon. Basically, that's their gold standard of how they diagnose people. So they will basically they will go through categories of, okay, this person has this symptom, and then they do this, and then they feel this, or they talk to people, they hear voices in their head, or they've been depressed for this many months. And it's like a lot of pie charts and bubble charts, and they all lead together. Boom, they have this diagnosis. Sometimes that's really how they're giving you a diagnosis, and they don't always get it right, believe it or not. Probably doesn't surprise you. Sometimes they have to play interview skills for a few times before they can get the right diagnosis. Okay, sometimes psychiatrists will go through a few different kinds of medication trials before they figure out what works for you, because sometimes they might think, oh, this person just has depression, so let me just give them some antidepressants. But then they give you antidepressants and your depression's better, but now other symptoms are unmasked, and now they've got other things that are coming out of the woodwork. So now they're saying, okay, maybe it's more than just depression, which is often the case. Okay, so the rest of this I'm going to go through real quick. I'll try to be done by I'm not going to try to keep y'all past 5, guys, I know, but whatever I don't get through today, y'all will be responsible for on your own, but just try to bear with me. I'm going to go through it fast. I've kind of categorized the different categories of mental illnesses, because there's so many different mental illnesses out there. I've kind of generalized them into their categories and how the ones that are similar, so you can kind of learn them like that. Okay, anxiety disorders. Anxiety disorders are the most common kind of mental disorder out there. Probably half of our faculty and student body at Pima could have anxiety disorders and may not even know it. There's generalized anxiety disorder, where you may just have heightened anxiety now and then. Panic disorders, PTSD is a type of anxiety disorder. Having phobias of things like spiders. If you have an aversion to spiders, and yes, a lot of people don't like spiders, but if you see a spider and you go ballistic and lose your mind and scream and run, then yes, that's an anxiety disorder. I'm going to go ahead and Mr. Allen is going to go ahead and say you have an anxiety disorder. Now, social phobias, like being scared of leaving your house, being scared of crowded situations, those things that now, so a lot of people don't like to be in like a crowded elevator, or a lot of people don't like to go to really crowded concerts. But if it's to a point to where it controls your life and it controls what you do or don't do every day, then it's an anxiety disorder. If it's just, I don't like getting in a crowded elevator because I feel like I can't breathe, right? It's going to fall. But if it was the only elevator working that day and you still could do it, then you're okay. You don't have a mental illness. Signs and symptoms. We've all had anxiousness before. So trembling, shortness of breath, chest pain, maybe your stomach hurts, dizziness. These can all be very minor, or these can be very, very strong. Heart palpitations, feeling like your shortness of breath, breathing hard. These can be very minor all the way up to very severe. Sometimes the most severe kind, people might think they're having an anxiety attack, a heart attack, because their chest is hurting and they can't breathe. They go to the ER, they're just having an anxiety attack. Etiology is not the cause of anxiety attacks are not understood. They are known, there is a genetic component, definitely, but most anxiety disorders they think they're rooted in a combination of genetic, psychological traits, and personal life experiences. So we know our life experiences during childhood affect us a lot the way we are as an adult. Other stats, females tend to have anxiety disorders a little bit more than males. These usually anxiety disorders are a young onset. So usually if you're going to have it, it usually comes on pretty early in life. And interestingly, one reason why they think it plays such a role in life experiences and memory is because that's the amygdala part of the brain plays a large role in anxiety. And when people are going through a lot of like an anxiety attack, they can do an MRI on them, and their amygdala, which has a lot to do with our memory and our fear, is lit up like a light bulb, which makes sense why PTSD people can have such hard times and have flashbacks and things. Treatment. The main two treatments are medication and counseling, usually a combination of the two. The meds they're going to be on are going to be antidepressants for depression, but they also have anti-anxiety and anti-panic attacks. Benzodiazepines are another kind of like that work immediately. So like you might have heard of Xanax and Ativan. You might be on those yourself. Xanax is like a party drug. You can get it anywhere. We all know this, but it's really a really good medication for anxiety. It works very effectively in the moment. The antidepressants have to build up in your system and work over time. So, and the antidepressants are not there to take anxiety away in the moment. You take those every day, and they work over time to have an anti-panic effect. Where the benzodiazepines, you take those in the moment for breakthrough anxiety when you can't get through it by yourself. Okay. Mood disorders is going to be the next type of anxiety, mental illness we talk about. So with mood disorders, these are going to be people that are going to be, these are people that are very, very, think of somebody, you know, that's very, very moody, but hold on, all my clocks are going off. Think of somebody that's very, very moody all the time, but when we talk about mood disorders, these people's mood swings are outside the norms of what we would consider normal mood swings. So when these people are really, really happy, they are like euphoric, like they're a little delusional, like a little too happy, like more giddy, like they've had 10 cups of coffee and their mind is racing 1,000 miles a minute, and they are just giddy and laughing. And it may be that bad, may not be that turned up, but you can just tell they're in an extremely good mood. Then they have periods of the opposite where they're in depression. It may be just depression where it's just a day or two of depression that just sorry, I just got a weird text. They may go through a few days of depression, but it's likely going to be a few weeks or a few months of depression. And these mood fluctuations go up and down all the time throughout their life. Now, there's going to be times when they're normal and they're going to be nice and steady, but then they're always going to relapse into what we call mania, which is the really good moods, or they're going to go into depression, which is the really poor moods. Both of these have the potential for side substance abuse or severe consequences, making bad decisions, or suicidal ideations. The first type of mood disorder we'll talk about is major depressive disorder. Now, this is different than situational depression. I'm talking what we talk about when we say somebody's like they're like, I'm just depressed. I don't know why I'm depressed, but I've been depressed for a few weeks and I'm just not a happy person. This is what I'm talking about. We usually just call that depression, but its real name is major depressive disorder. Situational depression is just what we feel like after a life event, like you break up with your significant other, or you have a death in the family, or you lose a pet, or you lose a job, or you get laid off from your job, or you didn't make the grade you wanted to make on Mr. Allen's test and he gave you a 77 and you thought you had an A in the bag. Then you're a little sad. It may last a couple of days or so, or for a death it's going to last a little bit longer, but it lasts for a certain amount of time. And then after time, we normally start to feel better and bring ourselves out of that state. That's situational depression. That is not a mental illness. That is not what I'm talking about here. This is true depression that doesn't really have a reason why you are feeling low and sad. So usually the criteria, you have to be depressed and sad for about 2 weeks or more. And yes, you have to be depressed for at least 2 weeks or more for them to even think about you being depressed. Okay. Then there's going to be other criteria they're going to look at. Is your mood depressed most every day, most all of the day? Do you have an interest in most of your things that give you pleasure, like your hobbies, things that interested you? Are you having weight gain or weight loss? Are your sleeping habits changed? You could be sleeping all the time, or maybe you can't sleep at all. You seem to be a little bit more agitated, maybe more fatigue, a lot of feelings of worthlessness and guilt, maybe even to the point of being delusional, where you start to believe that you're inferior to other people. That's true depression. And it may or may not come with thoughts of suicide. That doesn't have to come with depression. It often does eventually if you don't get help, but you have to have at least 5 of the nine of those symptoms, okay, for them to kind of consider you depressed. Dysthymia is another form of depression, or another mood disorder. It is another type of depression, but it's not quite as bad as real chronic depression. This usually it comes on at an early onset, and this usually because it's not as it's so it is a form of chronic depression, but it's less than 5 of the 9 criteria for regular depression. These people are still depressed, but just have fewer of the symptoms than regular major depression. But it tends to come on earlier in life. So in kids, it can come on as young as 2 or 3. And as you can think about it, if a kid that young is going through depression and they're battling it, then it's going to affect their cognitive development. It's going to affect their social development and things like that. So dysthymia is not really, it is a form of depression, but it does help if it comes on as a kid, it is going to affect their cognitive and social development, just because they're not going to be able to deal with learning and social situations the same as a normal person would. Okay. The next type of mood disorder, bipolar disorder. This is one that's very well known. It's probably the most well studied and documented mood disorder. Mixed periods of depression and mania, or a roller coaster of emotions. And there's two types of bipolar. There's bipolar type 1 and bipolar type 2. And the main difference, you ask, is, well, let's go to that space. Let's go to that. Well, let me talk about it. So in bipolar 1, you have what we call true mania and depression. In bipolar 2, you have hypomania and depression. Hypomania is really not much different than mania. It's just mania turned down just a little bit. But let's look at let's look at mania and hypomania. So mania comes from the French word manic, which means mad or crazy. So mania really does mean crazy, even though we shouldn't call these people crazy. And they're not. They just have a mental illness. That is a word you should never use to describe people that are mentally ill. So people that have mania are going to go through a lot of euphoria periods, thoughts of euphoria through their heads. They're going to have what we call delusions of grandeur and grandiose thoughts. So grandiose means thinking of yourself on a pedestal, but more superior and higher up than what you really are, almost giving yourself superhuman abilities, or like thinking that you're invincible, nothing can touch you. Delusions of grandeur are when you start believing those delusions in your mind. You actually start believing during that manic episode that, hey, I'm invincible, nothing can hurt me. So these people make really bad decisions and go extreme risk. It's really common that they go on shopping sprees. That is a really common question that psychiatrists ask when they're suspecting bipolar disorder or bipolar or hypomania or hypomania. They'll ask if they tend to go on shopping sprees a lot, to the point, not just like, now people can love shopping, but shopping sprees to the point where you spend all your money and then you can't pay your bills. And you may do this on more than one occasion. Hypersexuality is a huge symptom of mania or hypermania. Not just hypersexual with your significant other, but people may have these grandiose thoughts where they're invincible, and then they're hypersexual. Well, then they may go out and sleep with everybody they can find for every minute of the day and not even care about sleeping and drinking and eating. They're going to spend their money on prostitutes. They're going to spend their money on pornography. They're going to spend their money on whatever they can. They're going to have as much anonymous sex as they can when they're going through this, because they cannot see the consequences of their actions. They don't have to sleep. They may also have hallucinations while all this is going on. So as you can think, during manic episodes, if they're not on medication, they can ruin their bank account overnight. They can ruin their marriage really fast. They can lose their career. They could have had a whole career. They can ruin it overnight. They can ruin their reputation if it's not taken care of. They can ruin their credit. They can lose their house, all just by making bad decisions and having bad consequences of their actions. Now, this manic mood doesn't mean they're stuck like this and last forever. They just cannot see the consequences of their actions, and they're feeling they're invincible. they will eventually come back down into depression, into a crash. Okay. And then when they crash, they're really going to crash, and they're going to realize all the consequences of their actions, and they're going to beat themselves over it over and over again. Okay. That's the next stage. That's the next um, roller coaster they have, is depression. Well, hypomania is almost exactly the same as mania, but it's just mania not quite as bad as mania. So it may not be quite as, they may not be going on quite as bad spending sprees, and those delusions may not be quite as severe, and they may not be making quite as many poor decisions, and maybe they know they're hypersexual, but they're trying to keep it under wraps, and maybe they messed up a time or two, but they know they're in hypomania, so they've got to keep themselves under control. Those people are in hypomania. It's mania turned down a little bit. Now, mania will happen if these people are not on their medication, but it can happen with medication too. How they're going to diagnose you with these, I need to get you out of here real quick. They're going to basically see how often you're fluctuating through mania and depression, and then basically how bad the mania is. Then they'll basically say you're bipolar 1 or bipolar 2. That's basically the whole diagnosis. It does appear to be genetically linked on the X chromosome, but there's no conclusive evidence yet. Treatment. Let's go into treatment for mood disorders real quick. It's going to be a combination. It's always going to be a combination of counseling and medications. They can't have one without the other. Now, it doesn't mean they're going to be in counseling for the rest of their life for these disorders, but maybe they do, or maybe they need maybe a monthly check-in or a periodic check-in, but most of them are on some type of formal therapy program. Okay. What drugs are they taking? Antidepressants. Tricyclics were the old ones, but they could be fatal with overdose. The new ones are SSRIs, much safer. You can't overdose. And the MAOIs are good. Don't worry about bupropion. Read this slide real quick on your own. I want to get through mood disorders and then we'll go, okay? Medications for mania or hypomania. Is lithium is something that is a really good medication for mania and hypomania. It's just the solid form of lithium, the same thing that goes in your batteries. They've been using lithium for a very, very, very long time, so they know that it works very well. But you have to have the lithium blood levels checked every so often. And those can go unstable sometimes and be toxic to your liver. So most people, for their mood, and lithium is given as a mood stabilizer, okay, to keep your mood stable and from going into the extreme highs into the extreme lows. The newer mood stabilizers are seizure drugs, and they tend to act really well because they slow electrical activity in the brain, and so they make people's moods more stable. People take anti-anxiety medications, antipsychotic medications, antidepressants, and usually it's a combination of all of those mixed together. Two people can have the same mood disorder and be on completely different regimens of medicine. Psychiatrists and psychologists will often have to play medication cocktail party for a while before they find what it works right for one person, because every person's brain is completely different and they don't know why people react to psychiatric meds so differently. So one person that's bipolar may be on one set of meds, while another person that's on bipolar that has almost the exact same level of symptoms, they may be on totally different medications. So different. And sometimes it takes a few years to get those medications just right. Schizophrenia, we'll stop here for today. This is a different class. This is not a mood disorder. Schizophrenia is a different class of mental illness all of its own. So I'll let y'all read that on your own. What I really want you to get out of this lecture is the mood disorders and the anxiety disorders. And at the last section of the PowerPoint, which is what do you need, how do you need to treat somebody with a mental illness, mostly how to talk to somebody that's going through a mental health crisis, that may be in depression, or maybe be in the middle of a delusion, and how you can talk them down, or maybe somebody that's going through a delusion and think they're out to get you, and maybe they're getting violent. That happens with brain injuries. That happens with mental illness. You never know when it's going to happen, and you may think that's never going to happen to you in your career, but you may think just because I'm going to work outpatient ortho and I want to work athletes, I'm going to be free from that. But guess what? Athletes have mental illnesses too. They just take medication for them, but they may have a mental health crisis with you one day. And TBIs may be just fine, but one day something may trigger them, and their behavior will get aggressive. So you never know. So all the little tips and tricks of the trade that I gave you at the end of this PowerPoint will help you out a lot. Okay, so it's after 5. So sorry I kept y'all after. So tomorrow is a long day with me from 12:30 to 4:30, but we only have one topic. But it's a good topic. It's a fun topic. It's limb loss. So we'll talk a lot about amputees and prosthetic limbs and stuff like that. And usually that's a topic that everybody enjoys and everything. And that'll be what lab is over all day on Tuesday next week. Okay. So before I'm going to stop recording.